Acute myocardial infarction is the leading cause of mortality and morbidity in the world. The preference of people for Western diet and Western lifestyle, and coupled with the growing incidence of obesity and diabetes mellitus, is contributing to the increasing incidence of myocardial infarction. Myocardial infarction, the cause of myocardial infarction is the rupture or the plaque fissuring that occurs in the myocardial blood vessels, and this leads to the exposure of the subendothelial matrix to the platelets and other thrombin materials, which aggregate and cause occlusive thrombus of the myocardial blood vessels. This leads to the acute ischemic attack in the myocardium, which again leads to decreased cardiac output. So this causes a temporary failure of the heart to be able to pump blood to other vital organs of the body. So and the whole scenario is called as acute myocardial infarction. Acute myocardial infarction can be broadly classified into ST elevation MI, non-ST elevation MI, or the silent MI. Now, the diagnosis of a MI is based on the ECG changes, and broadly it can be classified into ST elevation MI or non-ST elevation MI if there is an ST elevation. And based on this, the patients who have an ST elevation MI, they are eligible for reperfusion therapy through primary coronary angioplasty or PCI. Otherwise, if the patient has a non-ST elevation MI, we have to go for a fibrinolytic therapy. The ECG plays a very vital role in trying to establish not only the diagnosis but the course of action that has to be taken in treating the patients. Now, the typical symptoms of acute MI. The patient will complain of substernal chest pain, which is often referred to as severe or crushing type of pain that radiates to neck, jaw, the shoulder, or the right arm. In many cases, the patient can have pain in the above mentioned areas without having chest pain. So we should not confuse the pain in the neck, jaw, or shoulder, or the right arm alone, and this can be an MI. And at times there can be an epigastric burning sensation which can be confused with gastric upset or dyspepsia, but then this is not the case. At times even an MI can only present as an acute epigastric discomfort. Now the other thing is the patient can have severe sweating, palpitations, or shortness of breath. So if the patient has this, we have to take an ECG, and there is something called as cardiac biomarkers. The different types of cardiac biomarkers are creatine kinase, CKMB, and then troponin. In troponins we have troponin I and troponin T. So the CKMB is useful in gauging the size of the thrombus in the blood vessel and the timing of MI rather than in diagnosis. Whereas troponin and troponin T are very specific of the acute MI episode. Now the differential diagnosis of MI. The MI has to be differentiated from other pains that mimic an MI but they are not MI. Like we have acute pericarditis. The acute pericarditis pain, the patient complains of pain which is more severe when he lies down, but then the pain is relieved when the patient is into normal sitting position, the pain gets relieved. And the hallmark of this acute pericarditis is vague ST segment elevations which are very much vague. They are not confined to one lead. So this is the hallmark of acute pericarditis. Now we have something called as myocarditis. In myocarditis also it mimics MI, but then that is not an typical MI. Then you have something called as acute aortic dissection. In acute aortic dissection, what happens is we have a very tearing pain that radiates from epigastrium to interscapular region. If this happens, then we have to get a chest X-ray done, which may show a widened mediastinum. Apart from this acute aortic dissection, we have acute pulmonary embolism. Even this mimics acute MI. Okay, apart from all this, once the MI is diagnosed based on the ECG and cardiac biomarkers, then we have to think of the revascularization. The first and foremost and advanced technology for revascularization is primary percutaneous intervention or primary PCI, and the patients with an ST elevation MI, they are eligible for this. The time to reperfusion is also of paramount importance. Now if the patient is able to shift it to be an tertiary center where there are facilities for primary PCI, then from the first medical contact to the time for PCI, if it is less than 90 minutes, then we should shift him to a center whereby PCI can be initiated. But then if the time is less and we feel that the patient can't be shifted to a center where PCI is available, then we should think in terms of fibrinolytic therapy. And this fibrinolytic therapy should be initiated within 30 minutes of first medical contact. Now the choice of agents. For fibrinolytic therapy, we have starting with alteplase, reteplase, tenecteplase and streptokinase. Now alteplase, tenecteplase, they form the first line of agents, whereas streptokinase, it's a second generation agent for fibrinolytic therapy. Now the treatment of acute MI, it consists of giving loading dose of aspirin and thienopyridine like clopidogrel. Apart from this, we should be able to give patient oxygen and NTG infusion to relieve pain. So once this is done, we can think in terms of either fibrinolytic therapy or primary PCI. Now once this is done, we can see the regression of changes on ECG. So depending on this, we will be able to see whether the treatment has been successful or not. And then once this is done, then we should be able to get a 2D echo done, which will reveal about the regional wall motion abnormality and the LV function. So based on all this, we will be able to have a better view of the prognosis of the condition of the patient, whether the patient will have a long-term morbidity or not, based on these factors. Thank you.